Thank you, Sister Ko, for the introduction. Hello, everyone. Good afternoon, and thank you for joining. I'm Fräulein, and today I'm going to give short lectures on cord prolapse. Cord prolapse is one of the obstetric emergency events, and most of the time it's encountered in the labor wards and required immediate delivery. So without further ado, here are some facts on cord prolapse. The incidence of cord prolapse is about 0.1% to 0.6%, although it is rare, but it's is associated with perinatal mobility and mortality. So the most common cause factors of cord prolapse is due to prematurity, breach, and also abnormal lie. The cord compressions or vasospasm will result in birth asphyxia or birth brain injury. Therefore, early recognitions and interventions are very vital to reduce the adverse outcome of the fetus. Alright, by the end of this lecture, you will be skillful in the early diagnosis of the cord prolapse and able to manage cord prolapse promptly as multi-professional teams, and you're able to provide safe transfer of cord prolapse in facilities if your facility are inadequate. Right? For the definitions of cord prolapse, there are two types of cord prolapse, which is overt cord prolapse or presentations. Overt cord prolapse is the most common type, whereby the umbilical cord come out of the cervix or the vagina before the presenting part. Meanwhile, for the occult cord prolapse is the situation where the umbilical cord lies trapped beside the presenting part rather than below it. It can happen with ruptured membrane or membrane intake. When the presenting part starts to compress on the cord, it will reduce the oxygen supply to the fetus, and the baby will develop hypoxia and eventually will develop hypoxic ischemic encephalopathy, which is HIE, or we can say brain dysfunction or even stillbirth. Okay, take a look at this picture for the better understanding on the definitions of cord prolapse. This is the situation of overt cord prolapse. As you can see, the membrane, the amniotic membrane is ruptured and the cord is coming down first into the cervical canal. This picture you can find in our ICO handbook at page 170. Okay, the second picture you can see the overt cord presentations. Why we call it presentations? Because here the amniotic membrane is still intact, but the cord is coming down in front of the presenting part. And for the occult cord presentations, you can see the umbilical cord is lying down alongside of the presenting part and it's not coming down. So well, from the picture, we can understand that high presentation is one of the risk factor of the cord prolapse. As you can see here, the space at the side of the cervix will easily allow the cord to slip down. There are several other risk factors of cord prolapse. For instance, for non-iatrogenic or iatrogenics. The most important risk factors is malpresentation. As we all know, a normal presentations is known as Catholic presentations, where the head is come first. But in malpresentations, either it is in breech or transverse lie or oblique lie, there will be more space down the cervix, and the possibility of the cord to come down or slip out into the birth canal is very, very high. Same goes to the polyhydramnios. Polyhydramnios is the situation where the amniotic fluids is a lot and may cause you trying to over distended. Frequently will associate with malpresentations. And when the ruptured or the membrane is ruptured, normally the sudden gush of water will sometimes predispose the cord to slip out. While in the twin delivery, sometimes it's also associated with the malpresentation of the second twin. Normally, the second twin will come out in breech presentations, and the breech presentation is very risky for the umbilical cord to come down first before the fetus buttock. For the spontaneous rupture of membrane, either it's SROM or PPRM, the high possibility of cord is to slip out also is there. Prematurity, IGR, SGA, when the mother go into the preterm labor, the fetus size is small. So there will be more space alongside of the cervix for the cords to prolapse. Amniotomy, when you do the amniotomy with an engaged presenting part, the risk of the cord prolapse is very high. Placement of the cervical wrapping balloon catheter. This one most common will happen right after the catheter being removed, either it's spontaneously removed or manually removed. And also the external Catholic version, which is ECV. Right? So the amniotomy must bear in your mind the amniotomy should be avoided if the station is still high to prevent cord prolapse. All right. How to recognize the cord prolapse? The most obvious signs of cord prolapse is when you do the vaginal examinations. You can see the cord is protruding out from the vagina, or when you put your finger in during VE, you can feel the cord first. And also another way to recognize the cord prolapse is from your fetal monitoring, which is your CTG. All right, if there is a sudden changes in the CTG, such as early deceleration, bradycardia, or reduced fetal movement, or eventually stop the movement right after the rupture of the membrane. If any of the signs occurred, an acute event and make plan to expedite the birth should be considered. Here I would like to remind all of you, you should have a high suspicion of cord prolapse, particularly if there is a changes in your CTG soon after the rupture of membrane, whether it is spontaneously ruptured or by amniotomy. So, what are we going to do when there is a cord prolapse? If the fetus is alive, immediately call for help or press the emergency button. Arrange for the category 1 C-sections. Continue to monitor the fetal heart rate, and try to relieve the cord compressions by the flowing method until the delivery of the fetus, such as elevate the maternal buttock with 2 pillows, gently push the fetal head upwards away from the maternal pelvis, or you also can use another hand to apply the suprapubic pressure to keep the fetus away from the pelvis, and inflate the maternal bladder with 500 ml of saline, and try to put the mother in the Trendelenburg or knee chest positions. Take a measure to prevent umbilical cord vasospasm. Discontinue oxytocin. You can give tocolytic agents such as subcutaneous terbutaline, 0.25 microgram. Try to minimize excessive handling of the umbilical cord. And if the umbilical cord is outside, gently wrap and the exposed cord with the warm gauze. And deliver the fetus as quick and as safe as possible. The interval time from the decision time to the delivery time should be within 30 minutes. And you only can proceed with vaginal or instrumental delivery if the cervix is fully dilated, station 0 or minus +1, and there is no contraindications. Okay, where the resources are limited, you need to arrange for immediate transfer and maintain the decompressions of the cord. Communications is very important to the receiving center, okay, because when you're going to hand over the case, the receiving center should alert of the urgency of the delivery, and also good communication within your teams and the paramedic team, the receiving consent, the receiving center is very important. Do not miss out all the vital informations when you're doing the handover. In the event of the stillbirth, you need to aim for the vaginal birth with augmentation, unless if the augmentation is unsuccessful or if the lie is unfavorable, then only consider for cesarean sections. In the severe prematurity, the management is depend on the fetal viability or the neonatal care resources. Right. I will show the picture on how to relieve the cord compressions. Okay, the first one is, this is how we elevate the buttock with 2 pillows. Elevations of the fetal head using your fingers to relieve the cord compressions. And this is how we put the mother at the knee chest position, because the cephalate gravity will relieve the cord compressions. Likewise, there is a circumstance that you shouldn't do in cord prolapse situations. Do not push in the cord back to the uterus, because it may cause vasospasm and fetal hypoxia. And don't do the amniotomy if the mother already have a risk factor, as per discussed at the earlier slide just now, such as a high presentation, abnormal lie, prematurity, uterine fibroid or polyhydramnios, and avoid any excessive upward displacement of the presenting part during the amniotomy. Do not remove the finger once you diagnose cord prolapse to prevent the cord compressions. Avoid transfer the mother to another center in the knee chest position, because knee chest positions may compromise lower limb blood circulation, and it is impossible for you to put in knee chest position on the ambulance bed. The mother will be strapped on the stretcher. So perhaps elevate the buttock with 2 pillows will be the good idea to relieve the cord compressions. Right? Don't give oxygens in all the cord prolapse case. Avoid delay in cesarean section by trying to achieve vaginal birth and using all Doppler ultrasound to detect occult cord presentation is not reliable. Basically, the longer the delay, the greater the risk of fetal injury or the stillbirth. So this picture here shows us the proper way to handle the cord prolapse. If the cord is outside of the birth canal, you can use a warm gauze or warm towel, just gently wrap on the cord and without excessive manipulations to prevent a cord vasospasm. Risk management that need to be carried out in cord prolapse. Of course, documentation is very important. The time of the cord prolapse being diagnosed, what all the procedure have been performed, the decision time to the delivery time intervals, the ABGA score of the baby cord blood gases if available, and all the medication that been given should be documented. And then in cord prolapse situations, verbal consent is sufficient for the cesarean section. Good communication with the mother and the relative on the possible outcome is important. And when effective transfers of vital informations to the receiving center, including the urgency situation. Do not miss out all the vital informations when you hand over the case to the receiving center so that they can prepare the operation theater to avoid further delay of the delivery. Of course, the incident report after the event you should be triggered, and regular drills of cord prolapse is very useful, especially for the midwife that working in the labor ward. This brings me to the end of the lecture. Here I have covered on what is cord prolapse, how it happens, and why it is emergency situations. And also I have covered on the appropriate management in handling cord prolapse. Hopefully this short lecture will be beneficial to all of you in managing the cord prolapse at your practicing area in future. Last but not least, here are take-home message for you. Cord prolapse is uncommon, but it requires an index of suspicions to ensure early detections and also early intervention. It is a condition that requires urgent measures in timely fashion with multi-professional approach. Clear and accurate communications between medical staff, the receiving center, the mother, and the relative is important. Okay, thank you for your attention. If anyone have any question, kindly type at the comment below. I will be glad to answer them shortly. All right, over to you, Ko.
Thanks, Sister Fraulein, for giving us such a detailed presentation. I'm truly agreed with you with the points that all the labor room professionals, such as midwife and consultants, must be able to recognize promptly and manage cord prolapse appropriately in order to promote fetal well-being. Now, let's move on to the video sharing on the important tips of management of cord prolapse. Before we go through our video sharing session, I would like to thank to Dr. Guna, Sister Zuliza, and the team on this video recording.
Hello, good afternoon, madam. May I help you?
Priestess, my water bag already burst 1 hour ago.
Okay, alright. Don't worry, okay? Okay, come. I go bring you to labor room.
Okay.
Okay, madam. Any pain? Any fever?
No pain, no fever.
Okay, how about your baby movement? Is it active?
The phone is very strong, but now very less. Half an hour ago.
Okay, alright. Don't worry. I will check your vital sign first. Okay, give me your hand to me, please. Okay, so let me check your baby. Just take a deep breath. Okay, I just want to check the baby back and also the baby punya position. Okay, madam, I would like to examine you for the vagina examination. Right? Okay, just take a deep breath, relax, put your head up. On your leg, right. Just take a deep breath, breathe in, breathe out, breathe in, breathe out. Okay, madam, I would like to inform you vagina examination finding. So your cervix is open 6 cm dilate.
Okay.
But I would like to inform you, actually I feel cord before the baby head.
Oh.
So this is a dangerous situation. I would like to deliver your baby as soon as possible. So don't be scared, madam, alright? Don't be panic. It's everything in arrange, okay?
Okay.
So your baby will be safe. I would like to get a helper from my teams. Help, urgent! Yes? Okay, Atika, cord prolapse. Okay, I need you to activate red alert. Okay. Just over, madam. Breathe in, breathe out. Okay, breathe in. Okay, teams, this is a cord prolapse. Sister Chong, please put down the head. Izni, please take 2 pillows and elevate under the butt of the patient. Okay? And after that, Sister Chong, please ensure you stand by the CBD with 500 cc normal saline and inflate in the catheter.
Okay, madam, I set the 2 pillow.
Hi, that was a red alert.
Yes, doctor. So this is a cord prolapse situation. Patient G4P3, 36 weeks. Patient leaking but no contractions. So VE finding 6 cm dilatation, station -2. 2 pillow was elevated under the buttock and also CTG was normal CTG. I think she's really need emergency delivery.
Okay, Mrs. Aiko, don't worry. You've got the problem, emergency. You're alright. The baby's also okay, but we need to deliver you as soon as possible. The cesarean is the best and safest option for you. Okay? So, sister, leave your hands there. Make sure the head is not compressed. Keep the buttocks elevated as well. Has OT been informed, midwife?
Yes, doctor.
Okay, make sure you tell them it's category 1 cesarean. I want the anesthetist and the pediatrician there at the same time, okay?
Okay, doctor.
And sister, you continue documenting. I want both of you to help me transfer the patient's schedule right now, okay?
Okay. Okay, madam. Relax. Okay, we're going to transfer you to operation theatre.
Thank you so much for giving us such a informative video. With this, I believe all of you have a better view on the important tips of management of cord prolapse. For our second lecture, I would like to invite Dr. Tani Malai Jagannathan to share with us on our next topic, medical legal aspect of cord prolapse. Dr. Tani is an ONG consultant from Thomson Hospital and Avicenna Women's and Child Health Hospital. He was our past president of OGSM. Currently, he is one of our ICO steering committee and principal trainer. Now, we would like to invite Dr. Tani. Dr. Tani, the floor is yours.
Okay. Hi, viewers. I've been asked to touch base on the cord prolapse topic. What are the medical legal aspects of it? Usually, when you have come across a case of cord prolapse and have a poor neonatal outcome and maternal outcome, these are things you have been concerned of. As a midwife, you are the one as a first liner managing the patient and documenting as well. So let's look at what are the key aspects you play in management of this cord prolapse patient. First, as a lawyers or a medical legal expert, would you like to know what are the preventive mechanisms you did to prevent or prevention of the cord compression? That is, what are the measures you have taken to avoid the cord, umbilical cord being compressed with the presenting part itself so that it ensures the fetal circulation is maintained. So let's look. First position you can do is a Trendelenburg's position. That means you tip the patient's head down so that the fetus gravitates down so that the presenting part is not being compressed. First step. Second step is you can ask the patient to do a knee chest position. That means she stands in all fours where the head is down, the bottom is lifted. Number 2. Third, you can perform an elevation of the buttocks. That means by placing 3 or 4 pillows at the bottom and elevate the buttocks so that the head is down, the pressing part is pushed away by the compressing and preventing from the umbilical cord being compressed. Or you can perform a digital examination where the presenting part is pushed up so that the cord doesn't get compressed. Number 5 is insert a Foley's catheter and inflate the balloon with 500 ml of normal saline. The only problem is we have to make sure that you deflate the bladder before the delivery of the fetus. You shouldn't forget about that. Next, what are the preventive measures you have taken from prevention of the uterine contractions? First, most often we forget to switch off the oxytocin if you have started. So don't forget to switch off the oxytocin. Next, you can use tocolysis like abolition of the uterine contraction, sustained uterine contractions or intermittent uterine contraction by giving subcutaneous Bricanyl or terbutaline. The only problem is when you use this drug is after delivery, you might face some issues in uterine contractions or can cause postpartum hemorrhage. Then at that time, you need to use oxytocic agents. Next, during cesarean section, if the cervix is not fully dilated, you're required to perform an emergency cesarean section, which is category 1 cesarean section. What does it mean? Category 1 cesarean section means it is utmost urgency determines. That means from the time you diagnose the patient is having cord prolapse, you need to deliver the fetus within the next 30 minutes. That means decision to delivery should be 30 minutes. At that time, verbal consent, just informing the patient and the partner is good enough. Ensure at the time of performing when cesarean section, the fetal heartbeat is present at the time of skin incision, just before the skin incision. The cesarean section should be performed by the senior most personnel and experienced personnel. And there should be a pediatrician should be in a standby for the neonatal resuscitation of compromised fetus being delivered. Ensure the bladder is deflated at the time of delivery, just before the delivery, because when the surgeon is rushing to enter into the peritoneal cavity, if the bladder is distended, he might injure the bladder and causes a lot of medical legal issues. So the bladder has to be urgently deflated and peritoneal cavity is entered, vesicouterine fold of peritoneum is incised and the baby is delivered. In case if the bladder is injured, you need to alert the urologist, call the urologist. You need to suture the bladder in 2 layers and the integrity of the bladder should be checked with use of methylene blue dye injection injected into the bladder to look for leak and maintain the CBD for 14 days. And after 14 days, do a cystogram to confirm that bladder is not injured, there's no leak, the wound has healed well, then you can remove the CBD and advise the patient to have a follow-up. And after delivery of the fetus, make sure you do a paired umbilical cord blood gases. That is, you need to take a venous sample as well as arterial sample, compare the pH, bicarb and base excess, because that is important to determine whether there was any HIE, cerebral hypoxic ischemic injury has taken place or not. So it is very mandatory as a practicing midwife, you should alert the practicing doctor and the OT staff to perform the paired umbilical blood gas analysis. Last but not least is the documentation. If all these events have not been done and not been documented, as an expert, when you look through the case notes, we find that we assume that these things are not done. So that's the reason documentation of time of events, what time the diagnosis of cord prolapse is diagnosed, what time the prevention of cord compression techniques is being instituted, what time the subcutaneous tocolytic agents has been given, what time emergency cesarean section has been called for, what time patient is being transferred to the OT, and what time the skin incision being performed. That means sequence of timeline events has to be documented. Number two, you need to document personnel involved in attendance. Usually after the code blue drill or code blue, we often, when you look at the notes, the documentation is poor. We don't know who performed what procedure, and after time things are lost. So make sure your person in attendance is documented very well. The sequence of maneuver used, how much was the fetal heart rate monitoring fetus was, and fetal outcomes have to be documented. Communication with the parents as well as with the patient should be done. Postnatally, briefing should be done by the senior most consultants at ward for the sequence of events. Last but not least, incident report has to be initiated, so that to look at the system in the hospital in case of cord prolapse work very efficiently or not. So the medical legal issues pertaining to this cord prolapse is, what are the prevention techniques of cord compression, prevention of uterine contractions, what are the issues encountered during cesarean section, and the documentation. Thank you very much.